Anderson, and yes, today I am going to start talking about tuberculosis in people with HIV, and this is a very large topic. Given the brevity of our didactic lectures, I thought today I'd start with strategies to prevent tuberculosis in people with HIV. I have no relevant disclosures. Our learning objectives, hopefully at the end of this talk, you will be able to name what are known as the 3 I's of TB prevention for HIV-infected persons, describe practical steps for implementation of these interventions, and review the role of antiretroviral therapy in tuberculosis prevention for people with HIV. Now, before launching into these strategies, it's worth noting just how significant a problem tuberculosis is for people with HIV infection. It is much because HIV renders individuals far more susceptible to becoming infected tuberculosis mycobacteria in the first place. Progression. The control of tuberculosis in the normal host is mediated by T-cell immunity, which of course we know is very much targeted and damaged by HIV. So this graph tries to show the relative risk of tuberculosis infection in patients with HIV according to their CD4 count. And you can sort of read this as kind of a time sequence of what might happen in a given individual. So the first thing to note is that within 6 months of becoming infected with HIV, a given patient's risk of developing tuberculosis actually doubles. And as that CD4 count declines and HIV disease progression, that risk continues to rise, as shown in the purple line, to as much as a estimated 7-fold increase in risk. Now, as I'm going to show in subsequent slides, starting antiretroviral therapy does have a helpful impact and does significantly reduce that risk. But even with fully effective antiretroviral therapy, achieving virologic control and a robust rise in the CD4 count, that risk of developing tuberculosis never comes down to what it was prior to HIV infection, and remains, even at best, approximately double that of a person without HIV infection. So that's why we see so much tuberculosis and why it's so much of a problem among our patients with HIV, and why we need to focus a lot of attention on prevention of that in the first place. What can we do? Well, the WHO has summarized 3 key interventions in a helpful mnemonic called the 3 I's, which stand for intensified tuberculosis case finding, isoniazid preventive therapy, and infection control. And of course, there is another intervention that I've alluded to, antiretroviral therapy. So these are really the 4 issues that can really help to prevent tuberculosis. And I'm going to walk through these. But before doing so, it's helpful to briefly review kind of the natural history of tuberculosis infection, because it will inform the strategies we use for prevention. So it all starts at the top with exposure to an infectious case. Okay. This is in individuals without HIV infection. It starts with exposure to someone with tuberculosis who is infective to others. It's inhaled through the lungs and then acquires a focus of infection in the lungs. Now, in most healthy individuals, 98% in fact, that initial infection will be contained by the host cell immune system and progress to a condition that we call latent tuberculosis infection. These patients are asymptomatic, although if you perform tuberculin skin testing, or certain blood tests, you typically will find evidence of tuberculosis infection. However, it is not active disease at this stage. And frankly, for most healthy folks, they will persist in that state and sort of a lifetime dormancy. Now, over the course of their lifetime, roughly 5 to 10% of patients will experience reactivation of that latent infection for reasons that are not entirely clear. The Mycobacterium tuberculosis manages to evade the host defense spread and develop a true course of disease, which is typically pulmonary. And then, of course, the cycle can start all over again. So again, this is in the immunocompetent host. Now, the dynamics are a bit different in persons with HIV infection. And the first difference, oh boy, here we go again. Now, let me try and get back. Okay, the first key difference is that following initial infection with tuberculosis, instead of 98% of people progressing to latent TB, only 75%, while 25%, 1/4 of people with HIV who are exposed to TB will actually progress to clinical dissemination and disease. The other difference is that the risk of activation of that latent tuberculosis is far, far higher in individuals with HIV infection. Instead of a 5 to 10% lifetime risk of that occurring, we're looking at more like a 10% risk of this occurring every year. So people with HIV who have latent tuberculosis infection, it's more likely than not that over the course of their lifetime, they will eventually develop active disease. So how do we prevent tuberculosis? We look at the same life cycle and we can identify sites of intervention that can help to reduce this risk. There's immunization, for example, with BCG, which doesn't afford a whole lot of protective benefit, although in children it does appear to significantly reduce the risk of progression to serious disease like bacterial meningitis. There is a treatment of active tuberculosis that's very important and of course relies on identifying those patients who have tuberculosis in the first place. Infection control practices also are going to help prevent spread from an infected patient to others. And then we can treat latent tuberculosis infection and thereby prevent any potential progression to active infection. Now, in persons with HIV infection, these same interventions all apply, and additionally, there is the role of antiretroviral therapy, which significantly reduces the risk both of acquiring tuberculosis infection in the first place and of progressing from latent tuberculosis to active disease. Well, by how much does ART help? It's been estimated from various studies that being on ART reduces the risk of a person with HIV of developing TB by anywhere between 54 and 92%. These are all high-quality randomized controlled trials. So it's a very significant benefit. Certainly nowadays we recommend ART for everyone. It's was always, however, an indication for initiation of ART if a given patient had tuberculosis. All right, now the first I, intensified case finding. So you cannot, treat someone with TB and reduce their infectivity to others until and unless you actually know that they have it. And so there's been a big emphasis on trying to improve early case detection of these cases for both its public health benefit and individual benefit to individual patients. The sooner you identify the tuberculosis infection, the more likely they are to achieve cure. And so how do we implement intensified case finding? Well, one very simple way to do it is to do a symptomatic screening of all of your HIV-infected patients at each and every clinic visit. And that sounds like a lot, but we're only talking about 3 questions. Have they had a cough or a fever or night sweats in the past 4 weeks? And if they say no to all 3 of those questions, then it's very unlikely that they have TB. If they say yes to any of those, it's worth a little more investigation. And that might involve getting sputum smears, a chest x-ray. That becomes very sort of dependent on the clinical circumstance. But a simple questionnaire at every encounter will definitely improve the yield, and it's been shown to do so, of improving case detection. Newer technologies, beyond smear microscopy also definitely have a role if you have access to them. The GeneXpert system, which involves molecular analysis of sputum, is far more sensitive than traditional microscopy. And hopefully that's available to you as well for working up possible suspected cases of active TB. All right, moving on to isoniazid preventive therapy. This, of course, is the concept of treating latent TB with a course of antibiotics. Most commonly, isoniazid for 6 to 9 months is used. There are alternative options as well. But this has a very significant impact also. And this study from Brazil sort of nicely showed just how much of an impact IPT can have on reducing tuberculosis rates among people with HIV, how much of a role antiretroviral therapy has, and how much both interventions combined will have. So if you look at the far right column in this table, you will see that patients with HIV who are given ART only, their risk of developing active TB was cut in half. Patients who were given isoniazid preventive therapy, their risk of developing active TB was reduced by 2/3. And the best results were achieved with the combination of both, which achieved an 80% reduction in the risk of progression to active TB. So clearly, these are 2 interventions that are both strong and synergistic and worth pursuing aggressively. Now, I guess the critical question is, when is IPT, isoniazid preventive therapy, appropriate? There's been a concern that, if you give isoniazid preventive therapy too indiscriminately, you might end up giving it to someone who has active TB and thereby risk incurring isoniazid resistant tuberculosis strains. On review of a lot of data around this, that fear appears to be fairly exaggerated. It doesn't seem to be nearly as big a risk as many clinicians perceive it to be. Nevertheless, it is not very difficult to rule out active TB in patients. And the important key here that should come out from looking at this flowchart is IPT is really only offered to patients who are feeling well. I mean, if you have any suspicion of possible, tuberculosis, then don't start IPT. Have them come back, and it's only when they have no symptoms that would be suggestive of TB that you would consider giving it. Now, in some places, it's reasonable to reserve IPT for those who have a positive tuberculin skin test or blood testing that suggests latent TB. Having said that, in some regions where there's an extremely high prevalence of tuberculosis, it's actually not appropriate to include that. And this is, I would include countries like South Africa in that, where virtually everyone in the country has latent TB. It's so prevalent there. Because these tests, it should be recalled, are not perfect. People can be anergic and give a false negative reaction to that test. Again, returning to the fears about incurring isoniazid resistance by delivering isoniazid preventive therapy, a number of studies have addressed this, and a meta-analysis concluded that the risk of causing that to happen is pretty low, and in fact crosses the threshold beyond which it's not even clear if it's statistically significant. So balancing these risks versus benefits very much comes down on the side of going ahead and administering IPT while making reasonable measures to exclude active TB. All right, infection control, critically important. Undiagnosed tuberculosis is very common in people with HIV. It's also very important for the protection of healthcare workers who have been found to be 5-fold more likely to acquire tuberculosis compared to the general population, owing to the nature of their work. Both outpatient and inpatient sites are potential places where tuberculosis can be spread. There was an especially alarming outbreak of what's called XDR TB, extremely drug-resistant TB, in KwaZulu-Natal in South Africa, and this really started at healthcare facilities. So infection control does not involve anything fancy, really. You do not need ultraviolet lighting to disinfect the air. You do not need fancy, expensive ventilation systems. In fact, natural ventilation seems to work better than do mechanical ventilation systems. It's also important to try and screen for tuberculosis suspects using those same 3 questions that I illustrated earlier for intensified case finding. And for patients who respond yes to any of those 3 questions, you put them in a different area, separate them from the other patients in the waiting room, or you bring them back very promptly to be evaluated so as to minimize their exposure to other patients. Cough hygiene can have a big effect also. Simply covering your mouth when you cough, that has actually a significant impact in reducing infectivity to others. So how do we implement the 3 I's? So the first steps are establish a written infection control plan and designate someone who can actually follow through and make sure these infection control implementations occur. So you need an infection control officer. It's not a highly burdensome job, but it needs to be someone's responsibility to make sure these issues are being addressed properly. Start with a very simple infection control interventions. Natural ventilation, keep the windows open where weather conditions permit, promote cough hygiene in the waiting room, separate patients who are coughing from those who are not. Screen your patients who have HIV for active tuberculosis at each and every visit using a very simple 3-question questionnaire, asking about cough, fever, night sweats. If they are positive for any of those 3 questions, then look into it further and make sure you're not dealing with active tuberculosis. If they're negative for all 3, you have reason to suspect latent tuberculosis, then this patient is a candidate for isoniazid preventive therapy. If they're positive for any of those, you are not even going to consider IPT at that visit, but you are going to work them up and make sure you are not dealing with active TB. So just to summarize the key points, people with HIV are at a significantly higher risk for tuberculosis as compared to those in the general population. Antiretroviral therapy dramatically reduces the risk of tuberculosis among patients with HIV. However, these individuals still remain at increased risk, even despite completely successful ART. And then the 3 I's of isoniazid preventive therapy, intensified case finding, and infection control are simple and effective tools for further reducing the risk of TB among these individuals. So I'll stop there and open it up to any questions and comments you may have.